Good morning, everyone. And for those of you joining on the East Coast, good afternoon. I'd like to welcome you to the 8th Annual Vitals Conference, Solutions for All, the Path to Healthcare Equity. We're excited and we're thankful to have you all join us today. My name is Kelly Zhang. I'm a second-year MBA student at UCLA Anderson and president of Healthcare Business Association. Vitals is a premier university-led event in the Southern California region for students, professionals, and academics focused on the healthcare industry. We're excited to bring you industry experts, thought leaders, and alumni at the forefront of change and innovation in healthcare. Over the last few years, the COVID-19 pandemic has brought health inequity into the limelight. In today's conference, we will examine where we currently stand across the many facets of healthcare, and we will explore what needs to be done to work towards a future of equitable healthcare. The conference begins now and ends at 4:30 in the afternoon Pacific time. You can find the detailed schedule of today's speakers and panel sessions on the home page and under the Sessions tab of this platform. Please note, there are 2 concurrent panels from 10:45 to 11:45 and 1 p.m. to 2 p.m. So please attend whichever session you prefer. While we encourage you to stay throughout the entire conference, you are able to come and go as your schedule allows. If you're experiencing any technical issues with the Engage platform, please utilize the technical support button on the lower right-hand corner. In addition, each session will have a Q&A box through which you can submit your questions for our keynote speakers and our panelists. Today, we'll hear from our keynote speakers, Dr. Medell Briggs-Malonson, Chief of Health Equity, Diversity, and Inclusion for the UCLA Hospital and Clinic System. A fireside chat between Rajiv Vernaki, President of Digital Platforms at Anthem, and Maria Filipova, leading expert in healthcare transformation. And lastly, Susan Tusi, Chief Commercial Officer at Illumina. Furthermore, our panelists will be sharing their insights on topics that include health equity in clinical research, role of artificial intelligence, women's health, and strategies about advancing health equity on the front lines. We're also excited to host the Bruin Tank Pitch Competition, featuring a diverse group of founders and VCs. Before we begin really quickly, I'd like to thank our corporate sponsors, Johnson & Johnson and DaVita. I'd also like to thank our Healthcare Business Association Vice Presidents, Fionn, Yuling, Alicia, Alex, and Diraj, and the rest of the Vitals Committee for their dedication and commitment in planning today's event. Now, I'd like to introduce to our first keynote speaker, Dr. Medell Briggs-Malonson. Dr. Briggs-Malonson is the Chief of Health Equity, Diversity, and Inclusion for the UCLA Hospital and Clinic System. She is also an Associate Professor of Emergency Medicine at the David Geffen School of Medicine at UCLA. Dr. Briggs-Malonson is a nationally recognized healthcare improvement advisor, innovator, and best-selling author. She has dedicated her career to advancing health equity within diverse communities. Dr. Briggs-Malonson received her undergraduate degree from UCLA, MD from Harvard Medical School, MPH from Harvard T.H. Chan School of Public Health, and her master's in health science from UCLA Fielding School of Public Health. She has received countless awards of recognition for her work, and most recently was named as one of the top 25 influencers in emergency medicine, in addition to being the 2021 Los Angeles Dodgers Healthcare All-Star. Please join me in showing a warm welcome to Dr. Briggs-Malonson.
Well, thank you so much, Kelly, for that warm welcome. And it is such a pleasure to be part of the Vitals 22 conference. And It is such a privilege just to be able to share a little bit about me, as well as our journey to achieve health equity. And all of you all that are attending this conference really are going to make a significant difference in how we advance health equity, as well as social justice without our entire community. So I'm going to share my screen so we can go ahead and get started. And as Kelly mentioned, my name is Medell Briggs-Malonson, and I am the Chief for Health Equity, Diversity, and Inclusion for the UCLA Hospital and Clinic System. And that means that I'm responsible for the strategic oversight of how to advance inclusive excellence, as well as overall equity for all 4, soon to be 5 of our UCLA hospitals and 200 plus clinics. I'm also a very proud emergency physician, in which I still practice in the ER every single week. And so that's so important to me in order to still be connected to not only my patients, but also all of the diverse communities that we serve. But I want to actually start off a little bit about talking about the road to success. And the truth of the matter, the road to success is never a straight line. And as many of us know, there tends to be peaks and valleys, there's lots of different curves. And what's really most important, though, is that you continue to move forward to get to your ultimate goal. So I want to just start with a little bit about my journey, and that will give a little bit more insight into why I've always been a warrior for health equity and what we can all do collectively through not only healthcare, but also business and policy and education in order to ensure that all communities have equitable opportunities to be as successful as possible. So this is me. This is me when I was approximately 4 or 5 years old. And this is also around the time that I decided that I wanted to be a doctor. I am the very first physician in my family, but there are several nurses. And it was actually around this time that one of my aunts, who's a nurse, she saw me playing with her stethoscope one day during dinner. And she came over to me and she said, "Sweetie, do you want to be a doctor?" And I was like, that's really interesting. Sure, that sounds like a great thing. The doctors tend to help people. I'll be a doctor. And it sort of stuck with me from there. But one of the things that I later realized in my adulthood was that my aunt planted the seed of where I needed to go, because she was a nurse, but she asked me if I wanted to be a doctor. Now, she said that because I think she recognized that there was a complete lack of not only women in medicine at that time, but definitely Black women in medicine at that time. And even still, right now, approximately 35% of all physicians are women, and only 2% of us are Black women physicians. So that was the seed that she planted that continued to blossom. And therefore, I actually did my undergrad at UCLA and majored in microbiology, molecular genetics with a focus on being pre-med. And then I matriculated to Harvard Medical School, where not only while I was there and taking care of patients individually, I realized that I really cared even more about populations and communities. So that's why I did my Master's of Public Health and Healthcare Management and Policy at the School of Public Health there at Harvard as well, to really understand what are all the factors that are rooted in community that actually drive health, and what are all those factors that we need to think about from a public health standpoint in order to improve the conditions of all within our country as well as globally. Now, after I actually finished my initial MD and PH training, what I did then is that I decided to specialize in emergency medicine. Now, the reason why I decided to specialize in emergency medicine is because it's one of the specialties, in my opinion, that we can actually take care of anybody and everybody, regardless of who they are. So it doesn't matter about your race, your ethnicity, your language, your ability to pay, your citizenship status. If you need care, you can go into an emergency room and we are there 24 hours a day to take care of you. So I returned from Boston and actually did my training as well as my chief residency at Harvard UCLA, really focused on our county population and our most under-resourced populations. Following my training, I again felt there's more that needs to be done. And so therefore I became a Robert Wood Johnson Foundation clinical scholar, where I focused my time as a fellow doing community-based participatory research and policy focused on improving the overall health outcomes of under-resourced communities, and especially under-resourced communities of color. So after that point in time, I actually then was offered a faculty position here at UCLA, and I joined as an assistant professor and as a quality officer of emergency medicine for the whole system. Now, part of my career that you're going to hear about has always focused on quality and patient safety. And the reason why is because we know that the quality of care that one receives tends to be a significant foundation to their overall health outcomes over time. And so although I was always interested in equity, equity wasn't really talked about then. Now, yes, health disparities were, and we're going to talk about that, but not really equity. And so therefore, quality and patient safety for me was the closest thing to actually really advocating for health equity for all of our patients. Well, the next part of my career, I was very fortunate to actually serve as the UCLA representative to help to build the brand new Martin Luther King Jr. Community Hospital in South Los Angeles. So I joined the inaugural executive as a junior faculty member to help to build the quality patient safety risk management infrastructure, as well as to help directly advise on how to develop all of the technologies from a clinical standpoint in order to promote high quality and patient safety, but also how we leverage technology to improve the overall care of our under-resourced population. And so this was a once-in-a-lifetime opportunity to build a high quality hospital for a community in South Los Angeles that needed it most. And so therefore, I always try to say that this is my third child in more ways than one. But what occurred was this night. I was still practicing as an emergency physician. I was in our Ronald Reagan Emergency Department on a late Saturday night. And then all of a sudden I heard overhead, critical pediatric trauma. And what occurred is that our EMS teams, they brought in a little boy, a little Black boy that was right around my son's age, who had been in a horrible car accident with his family on the 405 freeway. And what occurred is that when the paramedics arrived at the scene, they had no signs of life of the little boy, but they still transported him to our level 1 trauma center. And as the paramedics came and brought in the little boy, and I saw his mother there in tears and covered in blood, we looked at each other, and me and my whole entire team, we knew that the little boy had died, but we never leave somebody in the field as a child. And we all knew at that point that our patient was really now the mother. And it was important for this mother to know that we were doing anything and everything possible for her son. And so after we continued to comfort the mother, I knew it was time to tell her that we had done every single thing we could do to try to resuscitate her son. And we told her that her son had died. And this was incredibly life-changing, not only for the mother, of course, but for all of us in the room, and even for me. Because for me, being also a mother and seeing this young boy on the table, which is the same age as my son, it broke my heart. And it also showed me the fragility of life and how we have to make sure that we define our own paths in order to center what's most important to us. And so at that moment, that's when I actually started to think about what's the next phase of my career. And so what I did after that is that I actually started 2 different companies and transitioned away for a moment of time from administrative work. I actually started my own personal brand, which was really focused and rooted in speaking engagements and speaking about health equity and workforce diversity and really overall healthcare awareness. But I'm a techie at heart. And so what I also did is start a national advisory firm that actually provides clinical expertise to help technology companies and investors in order to think about how to utilize technology in a more effective way to advance quality, patient safety, and overall equity, especially within diverse communities. And that company is called Contour Health Solutions. Well, as I was running my companies, I'm never too far away from UCLA. So UCLA actually asked me to come back and now also serve as a director of quality, again, overall the system, but also serve as the medical director of clinical effectiveness to think about how we add the greatest value possible to the services that we provide, and also think about how to do it in the most compassionate, high quality, as well as culturally aligned way. And then following this time, as we've all experienced, COVID-19 hit us and we went deep into the pandemic. In addition to that, we had a national and a global reckoning after the murder of George Floyd. And at this time, UCLA Health decided that it was time for us to be even more intentional in our anti-racism work, even more intentional of advancing health equity and social justice. So I actually became the inaugural Chief of Health Equity, Diversity, and Inclusion for the health system. And that's, of course, my position today. So when we think about health equity, and notice I say health equity and not health care equity, and we'll talk about why that is, it's important for all of us to really understand even what that means, because there is a significant difference between equality, equity, and justice. So what is health equity? Well, this is a diagram that I love to use. And you all are going to see I use a lot of different illustrations. And what this actually does is this shows the difference between equality, equity, and justice. And so when you look at the first portion of the illustration, you see three individuals that are trying to watch the game down below. And they each have the same size step stool or box in order to stand on. So you first see a tall individual. That tall individual can see the game just fine. And then you have a second individual that, is over the fence, no obstruction to the view. But then you have a third individual that, regardless of that support that's there, they still can't see the game. So this is the assumption that, once again, everyone benefits from the same exact support or the same exact things. And that defines equality. So now let's go to the middle picture. Now we see that the taller individual doesn't have a box and really didn't need a box and can still actually take part in the game just fine. The second individual has one box and is still able to see the game below. And now that third individual that normally cannot even participate now has some additional boxes and can also have that equitable opportunity to see the game. So this is a demonstration of equity. When an individual, population, or community receives the items or the support or the opportunities that they need in order to have similar opportunities as others. This is equity. Now, you're probably thinking, why do we even have a fence to begin with? And that's where justice comes in. Too often in our society, we tend to have various different systemic barriers and structures that actually set up inequities, which we really just need to get rid of the fence. Because if we got rid of the fence or the systemic barrier or all of those other factors that have been perpetuated in our country for generations and so many other decades, then everyone has a just opportunity to take part in the game. So think about that. That is justice. So how does this apply to health equity? Well, health equity is when everyone has a fair and just opportunity to be as healthy as possible. Now, this illustration directly from the Robert Wood Johnson Foundation, which I love to also use because it still demonstrates the difference between equality and equity. And so the first top of the illustration shows all four individuals, obviously with different characteristics, but they're all given the same bike to go on a ride. And while three may be able to go on the ride, and honestly, two of the three are probably going to be uncomfortable because one's smaller and one's taller, the fourth individual that's right at the very beginning, who's currently using a wheelchair, cannot use that bike whatsoever, although they're all given the same bicycle. Versus equity, where we take into account each individual, who they are, their characteristics, their experiences, their needs, and now we make sure that they have what they need in order to go along the journey. And now you can see all four of them have the right type of bicycle for them to go on their ride. This is equity. So how do we actually bring that also directly into play with our overall communities and even healthcare? Well, this is a quote that I also love from Dr. Anthony or Tony Iden, where it says, when it comes to health, your zip code matters more than your genetic code. I'm going to repeat that again. When it comes to health, your zip code matters more than your genetic code. And this is all rooted in scientific evidence. So the Human Genome Project actually showed that regardless of our race or ethnicity, we actually share 99.9% of the same exact genetic makeup. So it doesn't matter our skin color, our eye color, the texture of our hair, what part of the world we live in, we are all 99.9% the same. But what occurs is that race and ethnicity are all social constructs that were artificially created in order to categorize people for various different oppressive behaviors in order to justify the slavery here in the United States being a perfect example for such, the Holocaust being a perfect example for such. And so therefore, we have to really get rid of all of those different social constructs and recognize that we're all connected and we're all 99.9% the same. And so therefore, when we're looking at our overall health and healthcare outcomes, we have to think about the real factors that actually lead to health inequities. And that's when we had to think through, what are those non-medical factors? Well, if you look at this individual here, this is a diagram. It shows all of the non-medical factors that are the greatest contributors to overall health and wellness. Now, I'm a physician and I can definitely feel biased and be like, listen, as a doc, I know that the care that I provide in the ER, in the hospital, in the clinic, that's what matters most for somebody's health. But that's not the case. And in fact, we know from all of our studies that only 20% of all the healthcare that we provide to an individual really contributes to their overall health and wellness. It's actually other factors, other socioeconomic factors, the physical environment, and health behaviors that makes up 80% of one's ability to be incredibly healthy and to live a life of well-being. So what are all of those different factors? If only 20% of healthcare contributes to one's overall health outcomes, well, what are these other factors that we can impact? Well, this goes directly into the social structural drivers of health. Now, these are also known as the social determinants of health. But the reason why I like to use the term drivers now is because it's not enough to say they're contributors. It's actually active. It's actually something that is propelling one's health to be optimal or propelling one's health to be suboptimal. And we have to start thinking about this as being action-oriented so that we can not only impact, but influence each and every single one of these drivers in each one of our industries. So there are 6 primary social structural drivers for health. Number 1, economic stability. And what you think about an individual's employment status, the amount of money they make, how much debt they have, directly contributes to their health. Because if they have a really good job that's paying a really good salary, the likelihood that they live in a really good community where they can actually go out and exercise, have access to high quality foods, also be able to see physicians of various different sorts, it increases significantly. But if you also may not bring in as much income, or you live in a more under-resourced community, the chances that you have access to high quality care, high quality housing, high quality foods is less likely. So that economic stability is a key driver of overall health. And this actually is directly connected to education. And when we say education, we're talking about literacy status, early childhood education, and even education attainment. So of course, we're here at a conference for the Anderson School of Management. And the truth is, whether you're a student or an alumni or a supporter or sponsor, the likelihood that you have attained a high level of education is almost 100%. And that education is directly linked to all of these other social drivers, because the higher level of education that you attain, the likelihood you're going to have more salary, more income coming in, which then also opens the door to many other opportunities to live a very healthy life, as well as have a greater sense of overall well-being. But that's not always the case. Not all people have access to high quality education. Not all people actually have where there are not barriers to higher education as well. So those are the things that we have to think about. And the neighborhood and physical environment. Now I'm going to tell you all, environmental justice has become one of my new loves and one of my new passions. So often we have ignored the impact of our environment on our overall health and well-being. And when we look at our neighborhoods in terms of housing or housing insecurity, which we're going to talk about in a moment, or transportation or walkability, or the amount of toxins that are in our water, or the toxins that are in our household, that plays a significant role in how healthy we can be. And it's just like, for instance, food security. If we don't have access to high quality grocery stores that have prices that are reasonable in order to ensure that we're getting the nutrition that we need, then how can we be healthy? And unfortunately, in some of our more under-resourced communities and populations, people do often have to make the decision, do I use my money for this food, or do I use my money to keep the lights on? And that's inappropriate. We as a society should never allow someone to have to determine if they put food on their table for their family or they keep the lights on. And then there's also community and social context, which drives health. And that's about how much an individual feels integrated into their community or society, the stress that they may feel. We have a lot of different evidence that when people's stress levels are really high, it actually produces almost like a fight or flight response as well, which can lead to greater heart disease, greater strokes, and many other cardiovascular events. Well, this is the same with racism and discrimination. We also have studies that when someone is subjected to racism or any other form of discrimination and bias, it also raises that physiologic stress response within their body, which of course you can then see how someone may have higher rates of blood pressure, higher rates of heart disease, and all these other factors. So in all essence, it's likely not genetics, because we know our genetics are the same. What it really is are all of these other factors that are risk factors of being subjected to racism and discrimination. And then last but not least, healthcare access and quality of care. It's so incredibly important in our country, and think we're so happy, of course, with the Affordable Care Act that there's been expansion of healthcare insurance, but there's still gaps, and not all insurance is the same. And so therefore, the type of insurance you have, if you have insurance, plays a significant role in one's health. The number of providers in your community that you can go to so you don't have significant waits in order to see a primary care doctor or specialist are also key. And then making sure that you're able to see clinicians and providers that are culturally and linguistically aligned to you are very important as well, so that you can develop that rapport, they can understand you as an individual, and that we can also continue to advance overall health equity and justice. But these are the primary 6 factors, but I want to bring up one other incredible driver of health, and that is actually technology. Technology is the 7th social structural driver of health. You're going to hear it here first if you haven't already heard it. And the reason why technology is so important, because we live in a technologic world, and now healthcare is so linked to technology. Business is so linked to technology. And so we've heard, of course, of the COVID pandemic about more and more about the digital divide, but this also plays a role in terms of overall health outcomes, because your digital access to not only devices and broadband and Wi-Fi are incredibly important to your access to communicate with your providers, your access to high quality health education as well. And there's also technologic literacy. Do you know how to use those various different devices? And that's something that we see with our older population at times, or some of our other population that most of our devices are in English, but English may not be the language that that individual speaks. So it sets up more of that divide as well. So it's important for us to think about now technology as the seventh social structural driver of health, and we have to include that now as well. So what do we do about all this? How do we actually now start moving forward? Well, I want to actually give a very short example of how we take into account all these various different drivers, and we set up a system or program in order to do so. And so I want to just highlight one of the many health equity initiatives that we're launching at UCLA Health. And this is our Homeless Healthcare Collaborative, a community partnered care directly to our community. And so the purpose of the Homeless Healthcare Collaborative and the mission of it is to promote greater health equity and an overall improved clinical outcomes for people experiencing homelessness throughout the Los Angeles area. And the goal of this initiative is to provide highly comprehensive, high quality, equitable healthcare and social services to those that are unhoused throughout the Los Angeles region. Now, just to get a little bit of insight into the homelessness issues and challenges here within Los Angeles County, just in LA County alone, we know that we have over 66,000 people that are currently experiencing homelessness. And the count is about to start in a couple of weeks, and we'll be able to actually see even more of this. But we do know that approximately 227 adults and children actually become homeless every single day here in LA County. And this is not only due to various different aspects, such as, economic aspects of being unable to pay rent or unable to pay mortgage, but also things such as intimate partner violence or domestic abuse, where women are fleeing with their children in order to find safety. So these are all the populations that we have to think about and have to figure out how we can better support them. And so our journey at UCLA actually even started with taking a look at people that were experiencing homelessness that were presenting to our emergency departments. And we found that over 85% of those experiencing homelessness were coming in for social reasons or coming in for primary or urgent care conditions that could be easily treated in the community. And so therefore we said, we have to do something a little bit better. We have to address the needs of those that need us most. And so therefore, we set up a larger homeless healthcare collaborative with several different partners, not only here at UCLA, but also expanding directly out into the community. And many of our different partners, of course, include, for instance, the hospital and clinic system partners, the School of Medicine, but even many of our strong affiliations and partners, such as Venice Family Clinic, as well as the other social sciences schools, philanthropy, our elected officials, and of course, our city and county health and social agencies. So what are we doing right now? Well, one of the key things that we're doing right now is that we now have medically equipped vans that are deployed throughout all of the various different areas of Los Angeles in order to provide services directly to the community. And the whole point of actually having the mobile units go out is that it removes all the traditional barriers of actually having to get in to see a doctor that may be a distance away. And by providing comprehensive, routine checking care, it also prevents unnecessary healthcare utilization for people having to come to the ER or to the hospital when their needs could have been more addressed directly where they are, whether they're inside of a shelter at that time, inside one of the tiny home villages, or even in their encampments in which they really don't want to leave at that time. So we actually have two primary different implementation phases, soon to be 3 and 4, but we're currently have already launched in our transitional primary care, where we're going to various areas, which I'll tell you next. But then our phase 2 is going to be expanding our fleet of vans in order to then have more of an enhanced transitional care model, where we will have multiple vans all the way up to 6 in the community, and using technology so that while our teams are in the community, we also have physicians in a central hub that can also do video assessments for all of the vans out in the community to allow us to have even greater reach. So currently, what our vans do have is that we are literally a clinic on wheels. So what we do is that we provide preventative care services such as vaccines, disease screenings. We provide urgent care services such as laceration repairs, as well as treatment of infections. We also, of course, provide primary psychiatric and behavioral health screenings and treatment. On our vans, we have a full pharmacy where we can actually provide medications to patients right there and also give them medications to leave with. We also have a mini lab on the vans. And most importantly, what we're doing is also making sure that they have housing referrals and referrals for other social services, because bringing in, once again, the idea of health equity, we can provide the best care possible, but if we're not getting them into permanent housing, they're never going to be able to be as healthy as they can. So our current regions right now, we are in West Los Angeles, of course, because that's where there's a high density of people experiencing homelessness. And that is kind of what I call the mothership with all the hospitals and clinics. We're also in the downtown area by the convention center and the new crypto.com center, in which many of you all were familiar with that area, know that there's still a lot of people living underneath the underpasses and in other regions. We are also deployed down to South Los Angeles and working with many of our social service partners down in South LA, as well as our other healthcare partners. And we are also in the North Hollywood area, specifically providing care in the tiny home villages, where right now they need a lot more primary care as well as referrals for specialty care. Now, data is key. And so therefore, one of the very important things that we're also doing with all of the various different encounters that we're having is making sure we're tracking key metrics in clinical operations, looking at our healthcare outcomes in order to ensure that we're improving the health of those that we're serving, taking a look at overall service utilization. Are we able to get our patients back into their primary care home? Are we decreasing the rates of unnecessary ED visits or hospitalizations? But then also centering that fact about social service referrals, such as referrals to housing, as well as employment and social services, legal services. Soon to be, we're also going to be partnering with some of our other partners from the community to take a look and supporting more of our undocumented residents as well. And then also making sure people get healthcare insurance, directly signing them up on the spot. But then we're also looking at the financial model of this as well. So we're looking at not only once we actually start thinking about expanding the model for reimbursement, but also the overall community benefits that we're having. So we can make sure that this program continues to be sustainable for as long as it's needed. So this is actually from our day of launch. This is the core leadership team, our HHC leadership team. And this is from our soft launch on January 10th. And this also just shows you one of our vans in action. And this is a picture of the vans in the downtown area. And to date, we've actually, since we launched in January, have seen already over 350 people in multiple different regions throughout all of the Los Angeles area. So that's pretty significant in about 4 weeks' time during our soft launch. And during this time, have been able to get people referred directly into one of our clinics for specialty care if needed or others, as well as making sure that people have the medications that they need. And we actually come back and do follow-ups to make sure that they're getting better as well. This is also another picture of my teens directly in the tiny home villages in North Hollywood. You actually see two of our nurses here, as well as Dr. Gerardo Moreno, who is the chair of our family medicine department. And so this is huge also to have a chair of a clinical department directly out providing care to those that need it most. But one of the things that's really touching in my mind is just the optimism that's actually painted directly on these tiny homes. And for us, it's a privilege to also go out and be able to address whatever medical needs and be able to assist in whichever social needs that they have as well. And so in conclusion, I always have to have either Maya Angelou or James Baldwin as part of my presentations. And I thought that this quote from James Baldwin was a really important one when we're thinking about humanism and when we're thinking about how do we do more than just provide services to individuals. How do we make sure that people know that we care and that we're actively impacting all of the various drivers, all the various different factors that make one able to live the healthiest and most fulfilled life. And so this quote from James Baldwin says, "The world changes according to the way people see it. And if you alter even a millimeter the way a person looks at reality, then you can change it." So I want to thank you all for my invitation to be here at the Vitals 2022 conference. And I will pause and see if there's any questions.
Doctor, thank you so much for sharing your insights and the incredible education that you gave us today. We do have actually a few questions. I think we'll have time for 2 or so. So let's see. At a health system as large as UCLA Health, the impact of bringing more equitable healthcare to patients is, of course, enormous. And you've shown us through some of the initiatives that you've already implemented. For such large organizations, what would you say are some challenges or barriers in improving healthcare equity? So we have many healthcare leaders in the audience today. And so could you maybe speak to some, what blind spots or risks we should keep in mind as we work towards creating equitable healthcare in our own organizations?
Great. That's a wonderful question. And I would say that there are absolutely no risk of creating a more equitable organization at all, because that's what we all should be committed to. And that's what we have to proceed with intentionality. And so some of the pieces of advice I would actually give to especially many of the other healthcare leaders that are in the audience is, number one, there has to be true commitment to this. This cannot be performative at all. And so what that means by true commitment, there has to be an investment of people, there has to be an investment of finances, and most importantly, an investment of time and activities that are rooted and structured. So for UCLA Health, for instance, we have a full strategic plan that's actually dedicated to not only increasing equitable care and outcomes within the patients that we serve, but also making sure that we're contributing to impacting all of the social drivers in our community as well, in our greater community. And so one of the things that we've done in order to partner all of the strategies that we have directly within our health system to the strategies of what we're thinking about for community partnerships and engagement and influencing those other drivers is that we're now, for instance, an anchor institution. And so what an anchor institution, especially healthcare anchor institution, is a dedication and a commitment in order to utilize an organization's assets to partner with community and to once again improve economic opportunities, educational opportunities, as well as overall healthcare opportunities in the community and with community. And so that's where the commitment has to come down to. And I must say that this commitment, it cannot stay with your chief of health equity or your chief diversity officer. This is everyone's responsibility. And I can tell you one of the reasons why part of our momentum has been so fast at UCLA Health is because there's been a clear commitment from our very top leadership. So for instance, President Johnny Spizo has been completely committed to this in every single way, in which she's been very clear, even with all the other executives, that this is everyone's responsibility. Everyone will be held accountable for making sure that our organization becomes more equitable and more just, not only for the patients that we currently serve, but for all of the future patients we will serve and for our broader community.
Great, thank you so much. The next question we have is you have educated us today on the social structural drivers of health. The seventh one, the new one being technology. Zooming in on this, when you think about the next 10 years or so, what are the greatest opportunities that you see in technology? It comes in many different forms in terms of achieving greater equity in healthcare.
Oh, I love that question because again, I'm a techie. And I think that the horizon is so vast when we think about how we can leverage technology even more to truly accelerate health equity. But the number one thing that has to happen when it comes to building technology, and I'll also say for everyone that's in business, we have to center the voices and the experience of those that we need to serve. Too often, we have looked upon the development of technology or the implementation of technology from a very inappropriate lens of which we know better. We don't need to ask them what they need or what works best because we know better. And that's why our technology at times hasn't penetrated into the various different groups as much as we should. And that is another reason why we have started to see even more some of the divides. While some groups of various different social economic status are flourishing with technology, others are being left behind. So the very first thing in terms of advancing health equity is really, and I would say equity and technology as well, is really centering what the needs are, what the perspectives are, what the challenges are. And the only way we can understand that is that we go to the people, we include the people, we make sure that they are the experts, and we develop our interventions and our new devices and our new frameworks directly from what they think is best. So that's number one. I would also say that there's so much potential. It is time for our technology to move more into, instead of just being, oh, we're going to help out with this diagnosis, or we're going to help out with making sure we're providing this education, we have to now start using technology for true health management and true health optimization. And that means that the individual who's using the technology can actually benefit directly from it. But then that means we, as the various different providers and clinicians and other healthcare professionals and other innovators, can also help to innovate along that as well, so that it's a bi-directional relationship versus just us pushing things to our patients and our populations. So once again, it's about health management now and using technology. And once we get that fully integrated and no longer the silos, gosh, what we can do to improve health and equity is limitless.
Fantastic, Dr. Briggs-Malonson. We learned so much through your keynote today.